going. So welcome to our fourth expanded province-wide rounds. And today's topic is ethical issues in the COVID era. And we're going to talk about dialysis allocation and some ethical concepts. And so for that, we have our provincial interdisciplinary team of Rachel, Carson, Alice, Nina, and who are going to actually give you the overview, and Brian Forsley and Gayleen Hargrove, also part of this diligent working group, will be available to answer questions. I'll remind everybody that the question and answer bar at the bottom of your Zoom allows you to ask questions that we can either answer online or afterwards in the question and answer period. So without further ado, I'm going to ask Rachel to take it from here and give you an overview of some of the issues and problems and some of our solutions. There you go. Unmute, Rachel.
Of course, the standard Zoom comment. Thanks, Adeera, and thanks for inviting us to present this work. I was thinking yesterday, it's exactly 9 weeks, so it's exactly, I think it was March 23rd that Brian Forsley and I were sending around a few emails trying to sort out some thoughts around allocation and what if things got really bad. So what we're going to talk about today, we can go to the next slide. What we're going to talk about today, we'll have Dr. Preto and Dr. Virani, who are ethicists with PHSA, and they'll be reintroducing us or introducing us and talking about ethics that we may have been taught earlier in our training and how they shift during times of public health emergencies, specifically pandemics, and what concepts we would need to understand and potentially apply if demand for dialysis outstrips supply. So they're also going to touch on some of the potential pitfalls of resource allocation, specifically the idea is it ethical to consider age in allocation decisions. And finally, I'll spend some time outlining the proposed provincial framework that our working group has created in preparation so that we can plan in advance for potentially difficult times ahead. Next slide. So there are a lot of people who contributed to this work, and 3 of us will be presenting today, but the actual work was done by a very large number of people in a very short period of time. But only one person deserves to have her name in purple, and that's Sarah Thomas, who's brought her many project management skills to bear and coordinated and curated all the valuable input from all these people. And she really created this framework for us. So I should mention it's been on her evenings and weekends and early mornings that she did a stellar job. And we have Dr. Brian Forsley and Dr. Gayleen Hargrove, who took turns leading this work over the last 9 weeks, as well as the medical directors who reviewed and vetted the content. So it was really a privilege to be part of such a team effort across the province. So I'll turn it over to Nina and Alice.
So thanks everyone for having us today. I'm Alice, one of the ethicists at PHSA, and I think what we want to do in our ethics introduction is kind of start big and kind of then go small. So I'm going to spend a little bit of time talking about public health ethics and how it's a shift from our usual clinical ethics framing that we're perhaps more used to from medical training or from our day-to-day work. And then Nina's going to spend a little bit more time focusing on the specifics of the questions which came up in the dialysis framework. I wanted to just highlight this quote, and this I think is a good one to start with, because what it gets at is the numerous ethical issues and concerns that have been raised by the pandemic, and specifically in regards to renal and kidney care, some of the concerns that are coming up. So our experience suggests that medical centres must actively consider how to balance the effort to provide kidney replacement treatment care for all comers without compromising the ability to deliver optimal or even adequate kidney replacement treatment to patients with survivable and acute chronic kidney disease. We think it's time for medical authorities and ethicists to consider explicitly the possibility that kidney replacement will have to be allocated at this time and in future public health disasters. And so this is really a call to action for all of us to think about how we might allocate resources. And I actually had a conversation yesterday with HEC, who are the body at the ministry who are tasked with dealing with emergency responses, and talked to them about the work that the Renal Agency's been doing. And they are so happy and so grateful to hear about this work, because they say that there's been so much emphasis on ventilators, for example, in the pandemic, but really in disasters that they've seen before across the province and nationally, it's always in relation to dialysis, which really the crunch points come. So this is very timely work. Next slide, please. This is also just to recognize that there's been multiple bodies who have recognized the importance of looking into this question. So the global healthcare community and policymakers should anticipate and address the unique needs of different patient groups, such as those with kidney failure. So I think increasing recognition of the importance of this type of work. Next slide, please. Oh. So I do want to kind of highlight here that ethics has been in the news a lot during the pandemic. You can click forward. There's ethical dilemmas for governments and healthcare systems. There's recognition that we need to think about ventilators and what to do if ventilators or other areas of healthcare like dialysis run short. Keep going. Click. Questions in terms of research and how we should be conducting research in a pandemic, and ethical concerns around speeding up research. Next slide. And then questions really, centering on one will live and one will die. And I think these are the types of issues which have caught the public's attention and media's attention. And fortunately in BC, we've not really been faced with this yet, but it's important to be prepared and to plan. Next slide. And highlighted here also by the literature, which is recognizing in many areas that we need to think about fair allocation. We need ethical frameworks in place. We need to be able to have well thought through frameworks for rationing ventilators, critical care beds, etc. There's also some recognition that there's considerable moral distress involved in these types of decisions, and the director of the CMA a couple of days ago highlighted this in his national address, highlighted the moral distress of physicians and healthcare providers during the COVID pandemic. And I think that some of the work that you'll see with the framework today is that having a framework in place, a well thought through framework which people can turn to, actually helps alleviate some of the significant moral distress on providers during these crunch times. Next slide. So one thing which I think is helpful when we think about pandemics and where we are from an ethics perspective is we're all very used to focusing on autonomy, what's best for an individual patient, respecting individual choices, respecting informed consent, etc. We're used to trying to really understand what patients want, what they perceive their quality of life to be and their needs to be. When we shift into pandemic planning and pandemic times, we're really shifting away from this kind of focus on the individual and autonomy. And we're really looking instead at solidarity. And we're asking questions like, to what degree is it justifiable for a state to intervene on privacy and personal liberties of the public in the name of the greater good? And then we're also looking at if there's inadequate resources to respond to individual patient needs, how should resource allocation decisions be made to best serve the greater population? So you can really see that shift away from what's best for my individual patient to what's best to the public and our patient pool as a whole. And I think that frames all of our discussion. Next slide, please. BC has an ethical decision-making framework which has been set up for the pandemic. And the values in this framework I won't go through them in detail now, but the values in this framework are some which you'll be more familiar with, in terms of respect for persons and autonomy, minimizing harm through our policies and procedures, considerations of fairness and how do we distribute resources equitably, with consideration for social inequalities in health, for example. So these are the types of questions which have really come to the forefront. I think some of these other principles are real true public health principles which you might not be as familiar with. So things like proportionality. So if we are going to restrict people and restrict people's movement, for example, that needs to be proportionate in terms of the risks that we perceive. So as we're loosening up our restrictions right now, as we're allowed to expand our bubbles, all of those kind of things, it's because it's proportional to the risks of community spread right now. We know community spread's very low, so that we know it's okay to start looking at opening up our communities again. Next slide. These principles, I just wanted to kind of show you how they might apply. So in the PPE distribution framework, we applied these, the principles from the ethical decision-making framework and looked at how PPE should be distributed. And, PPE is a very common topic during the pandemic. And when we think about PPE, the way that the PPE framework was landed on was really that we need to recognize that there are some healthcare providers in our province who have very unique skill sets and who are going to be at the highest risk. So those who are in intensive care units, providing care to COVID cohorted patients, for example, have the highest possibility of transmission. And those individuals need to receive the highest priority in terms of PPE, because we want to try and retain their specialist knowledge for the good of society. So the idea being, if our ICU docs, for example, go down, then the rest of us will go down. Next slide. So I'll hand this over to Nina now to talk more about triage and resource allocation during the pandemic.
Thanks very much, Alice. Yeah, and this quote really sort of highlights, and it's a nice segue into this next part around resource allocation and the thinking about some of the principles and the values that sort of underlie these really tough questions. And these are extraordinarily difficult questions. These how do we allocate scarce resources? They exist even at the best of times. I mean, healthcare is expensive. Resources are always limited. And so particularly in a public healthcare system, decisions always need to be made about what will and will not be covered, and for what indications. But I think these kinds of questions come even more to the fore and more clearly into focus in a pandemic or public health crisis, exactly because they affect broader swaths of the population as opposed to specific patient groups. So what are some of the ethical values and principles? Next slide, please. It might be that, do we treat everybody equally? Do we give equal opportunity of access to resources? Or is it about treating everybody equitably? Giving more to those who have a greater need, prioritizing those who are the worst off. Do we adopt a more utilitarian approach in terms of maximizing overall benefit? That idea of the greatest good for the greatest number? Or is there something about building community solidarity that's also relevant here, as Alice just sort of noted, that idea that, we ought to be prioritizing folks who are in positions to further the broader public good in relation to the crisis at hand? And where does, respecting individual liberty come into these notions and to these decisions? There's, I think, a recognition that throughout, even though the focus is on the public, the broader public good, that to the extent possible, it is still important to respect individual autonomy, liberties, cultural safety, etc. And ideas around privacy and confidentiality are important here as well. Next slide, please. So if these are some of the values, the ethical values that we think about and underlie some of these decisions, how do we operationalize them? What are the kinds of principles that we would apply in relation to these decisions? And you know, I'll run through just a few of these right now in the interest of time, but you know, if we think about treating people equally, what does that mean? It might be by way of lottery or first come, first serve, sort of a random allocation. I'll talk more about the relative advantages and disadvantages of those in a couple of slides. So for right now, we'll move on to the favoring the worst off. And we might articulate this by way of sickest first, for example, but this raises some questions and some challenges in terms of the person's capacity to benefit from the treatment. Just by prioritizing who may be the sickest, we don't look at their ability to, to benefit from the intervention. What is their prognosis with the intervention? It also doesn't take into account trajectory. So it looks at who is the sickest right now. And if we think about this in the context of dialysis, for example, it doesn't help us think about the relative impact of on a chronic patient of being denied dialysis as compared to an acute patient. And it begs the question, should we require that chronic patient to become an acutely ill patient before we prioritize them? It seems problematic, and I think it seems problematic because in assessing this worst off, it fails to take into account what the chronic patient stands to lose. And so another way that we might think about favoring the worst off is by prioritizing the youngest first. And this conceptualization reflects the idea that those who have not had the opportunity to live as many years are worse off than those who have lived longer. And on the one hand, while this may resonate and has the benefit of applying to all of us, we're all going to age. We all stand to be equally advantaged and disadvantaged by this criteria at different stages. It also raises the problem in that it again ignores other kinds of relevant considerations, what our prognosis is with treatment and our capacity to benefit. It seems to suggest, for example, that we would always choose the younger patient, even if an older patient had a better prognosis with treatment. So it's important to note that prioritizing the youngest first in isolation from other relevant considerations categorically and arguably arbitrarily excludes older people. And that this is problematic ethically, but it also raises some potential legal concerns as age is a prohibited ground of discrimination under the Canadian Charter of Rights and Freedoms. So there are some problems there. If we shift to the idea of maximizing total benefits, that utilitarian notion, in the context of resource allocation and triage type decisions, this is generally conceptualized as maximizing number of lives saved. And however, life saved doesn't tend to look past hospital discharge, and many have argued that incorporating some sense of longer term life expectancy is appropriate when we think about maximizing total benefits in this way. As White and colleagues have put it, survival to discharge really is a thin conceptualization of medical benefit. And those authors and many others instead choose to maximize overall benefit by giving some priority to those patients who have some reasonable access or some reasonable prospect of surviving past hospital discharge. So bluntly, saving a life is good, saving a somewhat longer life is better in terms of overall benefit. It is worth flagging here, though, that while looking beyond immediate hospital discharge to short-term life-term expectancy might be appropriate, looking further down the road to long-term life expectancy has been recognized as problematic because it stands to negatively impact those who are already disadvantaged by virtue of diminished life expectancy associated with disability or conditions associated with socioeconomic status, unstable housing or food supply, etc. Alice touched on, again, instrumental value and reciprocity, so I won't touch on those here, and we'll skip to the next slide. So what I hope I've started to suggest in the previous slides is this conclusion that we can't rely on one of these principles in making our allocation decisions, and that in fact it is really about incorporating a number of different principles in order to achieve something resembling a fair distribution of resources in these complex decisions. Next slide, please. In addition, though, it's important that it's not just the substantive, i.e. the principles that we apply, but also the process that we apply that's important. Having a fair, open, transparent, inclusive process is an integral part of an ethically justifiable outcome. And one way to help enhance and promote good decision-making is having an ethical framework. This is a simplified version that came out of that's part of the ethical framework that Alice just mentioned, the BC COVID-19 ethical decision-making framework. And I think just to flag that, you know, there's nothing magic about an ethical decision-making framework, unfortunately. It's not going to just immediately give us the right answer, but what it does do is provide a fair, systematic, all things considered approach that can really help in situations where there's no clear answer. And in these kinds of situations, while what is decided is certainly important, the process is critical because it gives a basis on which people can agree, even if they don't necessarily agree on the outcome. And so, as Alice noted, it's also important because it alleviates or mitigates some of the distress of these decisions, both for the patients who are profoundly affected as well as those who carry the moral burden of making them. Next slide, please. So in terms of the specific allocation, the dialysis allocation framework, the principles that we landed on in our deliberations were, and drawing on other frameworks that have been, you know, in relation to ventilator allocation and other kinds of frameworks that have been developed, are the principles of maximizing benefits, both in terms of maximizing lives saved to hospital discharge and life years saved, so near-term survival. Treating people fairly, this idea that it's, you know, there are certain criteria that it's not appropriate to base decisions on, and that, such as, you know, socioeconomic status, ability to pay, etc., or criteria that in isolation don't constitute evidence-based clinical indicators, so age, race, ethnicity, etc. Ought not to be relied on in isolation as decision-making criteria. We also highlighted the importance of prioritizing the worst off, so noting that those who most need and can derive the greatest benefit ought to be prioritized. And then, as I've noted, this idea around the integral part of a clear, open, and transparent process. Next slide. So another aspect that we considered, though, was how do we proceed in situations where multiple people are similarly situated clinically in terms of urgency and prognosis, but so in the situation of a tie, what was our tiebreaker? And in this kind of a situation, you could reasonably adopt an equality-based tiebreaker. Two common examples would be this idea of first come, first served, or lottery. And each of these have their relative advantages and disadvantages. First come, first served, for example, treats people equally, but it tends to incentivize early presentation to hospital. You might come seeking care earlier than you otherwise would in order to get ahead in the queue. And this can result in resources being quickly overrun, for example. It also disadvantages those who get sick later, perhaps because they've adhered to social distancing measures and guidance better than others, or those who live further away are also disadvantaged. Lottery tends to also treat people equally. It's a random allocation. It avoids some of those disadvantages that we just thought about in relation to first come, first serve. but there are challenges in relation to operationalizing lottery, and it's also been discussed that there are fairness considerations. You know, you may have been waiting for a long time, and then people keep getting further ahead based on this sort of based on a lottery application. So there are fairness considerations there as well. Next slide. Thanks. And in relation, but so these are sort of equality-based tiebreakers, but there's also a more equitable approach that can be considered. And this is this idea of fair innings. And I think this is Dr. Michael McDonald, who was recently interviewed by Douglas Todd in the Vancouver Sun, and he referenced this idea of the, you know, what is the role of fair innings? And it's the notion that patients who die sooner or at an earlier stage of life are worse off than those who have had an opportunity to pass through more of life's stages. As others have put it, you know, it's always a misfortune to die. It's both a misfortune and a tragedy for life to be cut off prematurely. And so this suggests that that we might prioritize those not by age, but by age range. So those, for example, who would be within one bracket, whether that's say 12 to 40 as an early life stage, would all be treated equally. And I think the notion here really is that, you know, while data from public engagement events does support this idea of prioritizing based on life cycle, this is really very much rooted in a certain societal view, one that prioritizes youth and tends to undervalue or underprioritize the elderly and seniors. In cultures or societies where this isn't the case, where, you know, premium is placed on the wisdom and the insight and of the elderly, be it for continuity of culture or for its own inherent worth, the views may well be different. It also is worth flagging that, again, this could potentially be subject to a legal challenge if it's deemed to be discrimination on the basis of age. We have sought some initial legal input on this question, and that seems to be unlikely, but we are seeking further legal input. So in our framework, we did adopt this as the initial tiebreaker, and then went to a lottery-based system if further tie-breaking was needed. Next slide, please. So just very briefly, basically, and in the interest of time, I guess I'll actually stop there. But I wanted to just note that, again, you know, we can look to the past to really understand that proceeding without clear ethical guidance and a clear ethical decision-making framework places a huge moral burden on those who are making the decision, as well as not necessarily resulting in the best decision for the patients whose lives are profoundly affected. And so this really does highlight the importance of this work and having a clear process in place. And with that, I will pass it on to Rachel, who will introduce the framework that we've developed.
Sounds good. Thank you, Nina. And just for those who may not realize, the photo is from a 1962, I believe, Life magazine spread of the Seattle God Committee, which is the original committee looking at allocation of dialysis when it first became available. Next slide, please. So I'm not going to try and convince you that COVID can impact renal programs or make renal patients sick or make people who were otherwise sick into renal patients. But I think really there's been an enormous amount of public and professional discussion around ventilator allocation, and that's really sort of seized everyone's interest. And that's warranted. But there's also an old saying that, you know, every mother crow thinks that her baby is the blackest. And so I think naturally we're biased to think that renal patients are particularly complicated. They're the most complicated of all patient populations. And at the risk of offending any intensivists in the crowd, I think in this case, when we actually started to figure out how to approach the problem of deciding who gets dialysis in a crisis situation when there really isn't enough resource, it's actually more complicated than deciding who gets a ventilator and who doesn't. So first of all, there are not that many outpatients using ventilators on a chronic basis to survive. There are some, but not nearly as many as there are dialysis patients. So most of the time when intensivists are comparing patients, trying to decide if you have 2 patients in the same unit and only 1 ventilator, they're comparing apples to apples. They're comparing ICU patients. And they make that comparison based on prognosis and potential to benefit, the way Nina and Alice have described. Whereas with dialysis, as we've already talked about, we have two very different pools of patients. We have acute kidney injury, ICU or ward patients, and then we have our chronic population. And even there's a great deal of diversity within those 2 populations. So how do you fairly decide between an ICU patient and a chronic hemo patient if there's only 1 run spot? And somehow we have to fairly assess and compare prognosis in apples and oranges, to put it bluntly. But that's not all. If you need a ventilator, and there are really only 3 things that get you in the position of needing a ventilator, there's low oxygen, there's high CO2, and there's airway protection. And if you don't get a ventilator in those situations, the outcome is fairly predictable. But as we know, dialysis is indicated for a really diverse set of reasons, and the outcome if you don't dialyze is less predictable, and the scale of urgency of need for dialysis really has a greater breadth than exists for the urgency of ventilation. So what we found was we have a lot of different dimensions to consider. We have 2 very different populations that are diverse even within their pools, and there's variable urgency of need. And so what we realize is we really need to consider multiple dimensions here. And so what we found was that we have to figure out more than just a simple matrix going forward. And there's no real guidance for this question. There isn't anything in the literature. There's nothing published from professional societies, and hence that C. Jason recent article calling for some kind of a framework. So here we are. And finally, given that it's really quite complex, as Nina alluded to, it's really important to establish this in advance. And I'm having worked on this now for 9 weeks. I'm very grateful we didn't have to do it in 9 days or 9 hours. And I'm very grateful we had the resources provincially and clinically that we've had to sort of really reflect and think this through in detail, because it's been really quite a process. And during that time, we're very lucky that our system's been remained fully operational and resource rich in the general sense from a dialysis perspective. Next slide, please. So what we've established is that allocation is going to be complex, and our goal is really never to get into a situation where we simply can't dialyze all those who need it. So really the first priority in terms of planning is to maximize capacity and get ready for a surge. So the whole framework can really be boiled down to 3 things, which is expand capacity so you don't get into an activated crisis triage protocol. If you do get into that situation, have a protocol for making those very difficult choices. And then throughout, communicate with patients and their caregivers. And I'll just quickly mention that we had patients involved in creating this framework, and their input was invaluable throughout, and communication really came through loud and clear. Next slide, please. So this is just a photo of the somewhat complex table that's in the actual framework itself. And again, really it can be boiled down to 3 fairly simple stages. It's 4 stages, but there are conventional operations at stage 1 and 2. And it's progressing through from conventional to contingency and to crisis level. And we've divided that into 4 surge levels. And this table references exactly what should be happening at each program for each level of surge. And I'll go through each level in a little bit more detail. Next slide. So it's actually staffing that's anticipated to be one of the primary resource limitations. So there's been a lot of discussion do we have enough ventilator machines in various places, but for our purposes, we are concerned that staffing is actually probably going to be the biggest problem, in particular because COVID's an infectious disease and staff might become sick. Physicians and renal techs are obviously potentially in short supply as well, but I think our biggest worry is nursing staff availability. And then our secondary limitations we considered were hemo machines, water treatment equipment, in particular portable and plumbing options within various older buildings. So for instance, in my hospital, which was built in the late or early 60s, the floor that was chosen as the COVID ward didn't actually have any plumbing for acute dialysis, so that we're busy retrofitting for that. So infrastructure may be an issue in some facilities. Next slide, please. So at stage 1, it's really business as usual, a little more business than usual, but still sustainable within the current model of care. And so, but at stage 1, we really need to take advantage of the opportunity to prepare for worsening strains. So this is where we can see a train coming, and we need to get ready. And part of that inventory is, that preparation is doing the inventory in advance of what flexibility you have for within the chronic patient population in your unit. So we created, the HEMO committees created a tables to sort of pre-categorize our patients into, to identify those that can really have physiologic resources to flex and to tolerate reduced dialysis dose in terms of reduced dialysis time or reduced frequency, whose potassium can be managed with Kayexalate and whose can't, to identify those people in advance so that you really have a good sense of what your usual and flex capacity is before there's a crisis in resources. So if you have these are stages of patients. So you have the well patient who can tolerate a 3-hour run for weeks, if not longer, because they have good residual urine output. And then you have your patient who's already dialyzing 5 times a week, already taking a binder on non-dialysis days and comes in with a 4-liter target every single run or a 6-liter target. So those, if you have a unit full of patients in category 4, category 5, you have really very little buffer or flexibility in terms of expanding capacity by reducing dose. Next slide, please. In stage 2, it's again still mostly business as usual. Things are getting tighter, and the idea there is to really shift resources into the in-center unit and patients away from the in-center unit in any way you can. So either to moving stable patients to community units where the ratios are lower, moving people who were candidates for home dialysis and fast tracking them into that alternate environment with expedited assessment and training, and by maximizing dialysis that doesn't use renal program resources, and that's mainly CRRT in the ICU. So at this stage, you're also redeploying staff from routine monitoring and maintenance tasks over to providing day-to-day dialysis services, and this is where nursing ratios may need to be adjusted. Kidney care staff or transplant staff need to be redeployed back into dialysis units to support capacity expansion. Next slide. So at contingency 3, I'm not going to read this all out, but really it says where everyone's starting to be pushed to their limits. So the patients who can tolerate it safely are on shortened runs. There are extended nursing ratios. We're moving patients from chronic patients completely out of regions where that are hotspots over to regions that have still have some capacity. So this is sort of the escalating crisis. Next slide. And then finally actually I'm going to pause here for a moment because again, this is something that really came out from our patient partners repeatedly, that as this crescendo is occurring, that there is a real need for repeated and proactive communication and transparency throughout these transitions. And that's something that the patients really emphasized, and that there's a great deal of anxiety obviously for everyone in these situations. But as things escalate, that transparency and communication about what's happening was really key for building trust and confidence. And they were very reassured actually, even in participating in the development of the framework, to sort of, and they said multiple times that, you know, we're really happy to hear that you're making this plan in advance. And if this is going to happen, it would be it makes us feel safer and less vulnerable to know this is happening now. And by extension, if it's happening in the real world, it would be helpful and make patients feel safer and less vulnerable to hear that and to find out what stage the unit is in. So that's important. Next slide. So when we get to crisis operations, this is where there really aren't enough resources to dialyze everyone who needs dialysis. There's escalating morbidity and mortality, and this is where moral distress becomes an even bigger picture for everyone involved, in particular clinical staff. Next stage or slide. So stage 4 crisis is actually a technical stage that's declared by the public health officer. And so there's a plan for that, at which point the Dr. Levin would then alert the health authority, renal program medical directors, and then those directors would activate their dialysis tripartite allocation triage teams, or for short DTATs. And this is a standard procedure or a standard infrastructure for making these kinds of decisions. Typically, it would be groups of 3 people, ideally the regional medical director, another nephrologist who's not on in the middle of the clinical situation that day, and either an ethicist, an allied health member who has some ethics training. And I gather that there's some options in terms of bringing in people from other regions if you're in a smaller center. Next slide. So the models that we developed to help was we assembled a multidisciplinary team from across the province. And again, Sarah Thomas did an incredible job coordinating all of this. We had patient voices advising us throughout, and we had this vetted through the programs, administrators, and nurses. And again, this transparent process is what we came up with in terms of making these difficult decisions, reminding ourselves that we really have 2 dimensions and 2 patient populations. Next slide. So this looks complex, and I have to say it is a little bit complex. So the idea of multidimensional triage, as I said, it's our baby's the blackest. It's really a combination of these 2 patient pools, and then using 2 different allocation concepts of both urgency of need as well as prognosis. And even within prognosis, there's short and long-term prognosis that we had to consider, and then applying that to 2 populations. So it is a complex algorithm, but it's necessarily so. And just one quick comment about the idea that the red, yellow, green. So intuitively, some of us think that green is go and red is stop, whereas in triage, red is the most urgent and green is things are good for now, this person can hold off. So next slide, please. So what we have is actually, sorry, go back. Sorry, Brenda, please go back 1 slide. Thanks. What we have are the 2 purple diamonds are the 2 patient pools. So if you're an acute patient, you start at the purple diamond at the top, and everyone's working their way towards the middle. And if you're a chronic dialysis patient, you start at the bottom and you work your way upwards from there. So patients, we started with urgency as the first urgency of need. So patients who are not at their physiologic edge, in the chronic population who can tolerate another day without dialysis, they go into the green group. And as Nina said, we decided that anyone getting to the edge of their physiology in the chronic patient population would be prioritized, because we didn't want to push those people and do foreseeable harm by making them become as sick as ICU patients in order to get their runs. And then at the same time, we have the acute kidney injury population at the top, in the top purple diamond, and they're going to work their way down. Again, the stable non-oliguric renal failure patient with preserved metabolics is going to go into the green group. They don't actually need, they might have a soft indication for dialysis, but it's not essential today. And then there's a heat map or a matrix of urgency and prognosis. So urgency is on the horizontal axis, and we've kind of graded into, you can probably do fine without dialysis today, it's green. And then the 2 rows in the heat map there are, you really need dialysis today. In fact, you need it right now. So your K is 9, you're having sort of some twitchy arrhythmias, or you're imminently going to need intubation because of volume overload. Versus the medium indication, where most of us would start dialysis in usual times, but there's possibility that this patient could get by without it. So we really separated that into multiple dimensions. And then the columns are prognosis. So you'll notice the blue column on the right. In triage, in military triage, there's black, which is in a battlefield, this person's has already died. And then there's blue, which is expectant or worst prognosis. So this is really looking at patients who, unfortunately, regardless of getting dialysis, their prognosis is really quite poor, and they would go into an expectant group. Now we can go to the next slide. So I'm not going to spend a lot of time on this. In terms of prognosis, there's been some work done out of Pittsburgh by Douglas White, who's a critical care physician trained in ethics, that as Nina alluded to, published a table about in 2009, so about 11 years ago, looking at this combination of near-term and immediate prognosis. So we used a table, we adapted that model and used a table that included SOFA score for the acute kidney injury patients, and then the Charlson Comorbidity Index for the more near-term out-of-hospital prognosis. And we chose the Charlson Index because it's relatively easy to calculate. It's a little bit involved, but it's possible with good clinical records. And it's also been validated in renal patients. So it's the most widely used prognostic scoring tool according to a recent meta-analysis and systematic review. And it's been validated by Brenda Hemmelgard and her colleagues in Alberta for dialysis patients specifically. So it's a little bit involved, but it's operational. We can operationalize this. Next slide. So coming back to, so again, it's a complex algorithm, and we don't have time to work our way through it specifically, but we feel that this achieved the goal of appropriately considering all those complex factors that we deal with in looking at these two different and complex populations. Next slide. So as Nina alluded to, if you have a tiebreaker, so let's say we go through our algorithm and we get a really, really big group of yellow patients who are all sort of stuck in the same group, but we have 15 patients in that category, but only 10 run spots. Then we would use the tiebreaker, so fair innings. So as an example, let's say you have your 15 patients and you allocate them in terms of their life cycle, and then you end up with 9 people in the top 2 groups and then only 1 spot for the remaining 4 people. Then we would go to lottery to choose 1 patient randomly out of that equally ranked group of 4 who are left. Next slide. So if all that sounds a little bit confusing or involved, it is. And so as we created this, we made a road test. So Dr. Brian Forsley came up with a simulation that, this is a really bad day at Penticton Regional Hospital in terms of the on-call nephrologist having to deal with a big set of patients. And so we made a simulation and then ran the algorithm. So next slide. And this is the Excel spreadsheet. So I actually sat down and did this, and it's a fair bit of work. There's no question there's workload associated with this to run the scores, but it was reassuring to see that, okay, this actually does work, and you can approach this in a methodical and ethical and sort of thought out way and come up with, at the end, when I look back at the patient list, it came up with what my initial gestalt would have been, and that was also reassuring that the results felt right from an intuitive perspective as well. Next slide. So there were a couple of concerns that did come up from the simulation, and one is well described, that the Charlson Comorbidity Index may actually miss patients with a poor prognosis if they don't have specific diagnoses that are used to give you points in the index. So something like frailty without other specific diagnoses. The simulation showed that there was 1 patient who was otherwise didn't have any specific diagnoses documented, and that person but was really quite frail. And so there are some weaknesses with this, and there are other clinical scoring tools that can be used, but they have their own issues and their own concerns. So one of them is the clinical frailty scale out of Dalhousie and Halifax, and that was used in the UK for the NICE guidelines, the National Institutes of Clinical Excellence guidelines, but there was a lot of outcry from the disability community of using the clinical frailty scale. So we chose the Charlson, acknowledging that that's a limit. As I said, there was a fair bit of workload to do this. And Nina's already alluded to the concerns about using life cycle as a tiebreaker. Next slide. So in conclusion, I hope we've given you a whirlwind introduction to public health ethics in the time of pandemics and how that's different from our usual operating principles. I hope I've given you a brief overview of the options for capacity expansion. And again, this is really quite a detailed multi-page document that Sarah has curated for us. that's, I believe, in the final approval stages in terms of making this available to programs. Again, to emphasize that regular and transparent communication is crucial for patients to feel safe and less vulnerable in these challenging times. Our considerations, we believe, are more complex than ventilator allocation, and that we really have created a novel tool that didn't exist prior to this work, in terms of a framework and a methodical approach that's grounded in ethical principles in terms of approaching these difficult decisions. The algorithm itself operationalizes these ethical principles to make good decisions under bad circumstances. And doing this work in advance is really a way to obviously help patients and make good decisions, but those good decisions in and of themselves can help mitigate our moral distress in these trying times. And with that, we're a couple minutes further along than we wanted to be, but we'll open it up for questions.
Yeah, thanks very much, Rachel, Alice, and Nina, and obviously the whole group that did all of this work. It's really quite transformational. It sounds complicated, as you say, but I think this notion that operationalizing the concepts into something that is usable is really important. One of the questions that was on the Q&A was whether or not, like, this is one 47-minute session or whatever, but is there a thought perhaps of educating people onto how to use the algorithm a little bit and sort of socializing it, or maybe even automating parts of it in Promise or other ways so that people get a feel for it? Maybe I'll ask you that.
I was actually going to say, do we have Sarah on the line?
Yeah.
Yes, I'm here.
Sarah, can I put you on the hot spot, in the hot seat here?
Sure, absolutely. Thanks, Rachel. We do have a template that we could share with anybody who is interested to do a road test within their unit or whatnot. I'd be happy to share that with you if you want to send me an email. There was talk about maybe it going on the website for anybody to do that, but we haven't quite decided if it's going to go there. But absolutely, be happy to share everything. Just send me an email.
Yeah, and I think that we might think about how best to do that. A couple of other questions, which sort of fits into this, the opportunity to do more simulations and get the teams doing these tabletop exercises. I think that's certainly a great way to also familiarize ourselves. I also want to really underscore, I know Rachel said it, but patients were at the table when you were having these conversations. And I think the fact that our patient partners have been involved in this and that we're able to articulate to our patients how we're doing this is a huge component to this, which really should be underscored at all times. Dan Martinson is asking whether patients could be transferred to other geographies to cope with surges in a hotspot. Yeah, absolutely. That's one of the things that we as a province can commit to, is that where there are hotspots in certain areas that aren't in others, we can move them. That creates a whole other, in a pandemic, moving people geographically creates a whole other set of complexities, but that was one of the intentions. Yeah, really great questions. There's a question answer. Oh yeah, I can answer live, thanks. There's a chat box as well. Just checking. Thanks, Sidoni. Yeah, so we were answering some of those questions live instead of typing them out. Other thoughts? Maybe for those of you that were around the table when the patients were there, like, what were their comments to you as you were going through this? I know that, I think Teresa was on the line today. Dennis is not, but I'm just wondering whether or not you want to reflect on what it meant for you guys having the patients there and what their comments were.
So I think, I don't know if Gayleen is there, or Brian, if you want to pipe up, but yeah, I think it was incredibly important to have that perspective. And it was, I think, I was very pleased we did that, because it was interesting as we talked with the groups of people looking at ventilator allocation. And I think my understanding is there's been obviously been a flurry of activity around the provincial ventilator allocation strategy, is that patients were actually they had originally had patients in their working group, but during the pandemic, they had stopped inviting them, which was interesting. So I was really pleased with that we stayed true to our processes and our that we did have those voices at the table. And as I said, they were really incredibly valuable at continuing to focus us on what mattered to the people at the center of this, which is really the patients. So, and it did come through repeatedly that it was reassuring to them that this was happening in advance.
Great.
It's Gayleen here. Can you hear me?
Yep.
So what struck me was that there was somewhat of a paradox in perception, I'll say, that we as healthcare professionals were worried that informing our patients of the possibility of the need for resource allocation would scare them, that we should actually, there was this idea we should withhold the information for as long as possible so as not to frighten them, especially if it would never be necessary. But in fact, our patients then, through their feedback and their commentary, it was actually the reverse for them. And correct me if I'm wrong, Rachel or Sarah, but it seemed to me that the more information they received from those who were directing their care and who were true to their word to be consistent in their care and provide continuity of care, was reassuring to them that we were planning ahead and that it was important for them to actually receive the details of what might lie ahead well in advance.
Yeah, and I think we sometimes forget that. And I know that there was a lot of work put into a couple of or more than a couple of different kinds of communications, especially to the hemodialysis, but to all the dialysis patients. And I think that those things which are available to all the programs are also really useful. They're done in a accessible language and help to explain to patients what's happening and why, even that their schedules might change, even if they haven't. So I think all of this work that you guys have done, both in this context, but also the commitment to ongoing regular communication with the patients around the changes that are going on, is super important. Just trying to see if there was any other questions that we could answer. We're close to the top of the hour, the bottom of the hour, I should say. I think this has been a tremendous amount of work by a number of people. 3 of you presented on behalf of the 15 that put the thoughts in, but I think all of us are super grateful that you've done all this thinking and that shared it so clearly with us so that we can actually learn from it. I think it's important to say that this sort of represents an incredibly mature approach to this problem. The 2 dimensions is novel. The 2 dimensions of the 2 dimensions is novel. And I think that as we work our way through this pandemic and Surge 2 and other things that will face us, I think this amount of work and thoughtfulness will really help us. So thank you, Rachel and Sarah and Alice and Mina and everyone else that worked, and Teresa and Dennis as our patient partners on this group especially, as well as Brian Forsley and Gayleen for their leadership in this area. And I think it's been yet another successful, almost 100 people on the call from the beginning. So thank you all. And I know Rachel's on call today, so off you go. Yes, yes, well noted. And again, thank you all for participating in the talk and also for all the people for listening. So until next time, much appreciated.